Good afternoon, everyone. My name is C.B. Mamrell, and on behalf of the National Coordinating Center for PHSSR and PBRN here at the University of Kentucky, I'd like to welcome everyone today to our PHSSR Research in Progress series, and our webinar focus will be on bridging health and healthcare. And we have an important and timely topic today, the Affordable Care Act and childhood immunization delivery in rural communities. And so I'd like to take the time to remind everyone that today's presentation is and speaker bios are available for download. If you look at the resource box at the top right corner of the screen, these are available for download. So please do take advantage of that feature. And so today we are pleased to have with us our speaker, Vaughn Do-Reynoso, who is the Public Health Director in Madera County, California, and a PhD candidate in Public Health Services and Systems Research in the University of California, Merced. Vaughn received her MPH in Health Policy and Administration from the University of California, Berkeley, and she has been a leader for Madera County Public Health since 2008. Vaughn has managed county behavioral health and human services programs since 2004. And she currently chairs the San Joaquin Valley Health Consortium, which engages public health leaders from 8 central California counties in strategic planning, training, policy development, and research to improve the quality and responsiveness to pressing public health issues faced by the counties in the region. Vaughn's prior experience includes operations planning with the Kaiser Permanente in Northern California operations and extended volunteer public health activities for an orphanage in Mexico. Vaughn is an active member of state and local health commissions and work groups related to medical benefits, public health leadership, and interagency planning. She is also one of our recipients of the 2014 PHSSR Pre-Doctoral Scholar in Public Health Delivery Award, or PPS PhD for short. And she has co-led the Public Health Delivery and Cost Study for the California Public Health Practice-Based Research Network. So it is our pleasure to have our speaker for today, Vaughn Do-Reynoso, to present today's topic. So Vaughn, please take it away.
Great. Thank you, CB. And the topic for my presentation is the Affordable Care Act and childhood immunization delivery in rural communities. And this is a research in progress. I'm covering the first phase of my work. Before we start, I want to take a second and acknowledge the Robert Wood Johnson Foundation for my Pre-Doctoral Scholar Award and the PHSSR National Coordinating Center staff, my mentor and thesis advisor Paul Brown, as well as my colleagues in Humboldt, Kings, Merced, Nevada, and Fresno counties. So just briefly to a snapshot of what's happening with the Affordable Care Act in California. In 2014, last year, we know that about 3 million newly enrolled folks got into Medi-Cal, and more than 1 million were newly enrolled in private coverage, private providers via the state exchange covered California. What we don't have yet is the gains from employment-based coverage. So even though we've made great strides in California, we anticipate that there still is about 2.7 to 3.4 million people under 65 who will remain uninsured by 2019. And so of this number, we're anticipating that around 50%, up to 50% will be undocumented immigrants, and the remaining number are eligible but are not enrolled due to a variety of barriers. What I'm interested in is, well, given the Affordable Care Act, what is the landscape for children? And so for children 0 to 17, about 8.3% will remain uninsured. And so for an estimated population of about 9 million kids, that's about 760 kids under 17 who will remain uninsured. And the other thing that's noteworthy is that under the Affordable Care Act, children who are enrolled in new group or new individual health plans are eligible to receive vaccines recommended by ACIP prior to 2009 without any cost-sharing requirements when provided by an in-network provider. So what does this mean? Does this mean that the increase in coverage translate to increase in access to healthcare services such as childhood immunization services? So in addition to the Affordable Care Act and the expanded healthcare coverage, there are other changes affecting local health departments in California. And my focus is on rural, small rural counties. And so California, we have 58 health jurisdictions, and 31 are considered small and rural. And that means less than 200,000 population size. So governed by the Welfare Institution Code 17,000, local health departments are responsible for the uninsured or indigent population. However, given that the landscape has changed, notably with the decreasing funding from the state in health realignment revenues and decreasing state categorical funding for immunization programs, that in combination with the changing federal vaccine guidelines, stricter guidelines on who's eligible for federally purchased vaccine, what's the new role for public health departments? Especially given that immunization is a core value, it's a core practice for local health departments, the struggle or the thinking is, what's the new role? Especially in small counties where access to immunization may still be an issue despite of the increase in coverage. So my study objective is to evaluate whether the Affordable Care Act has led to an increase in childhood immunizations in rural counties, and then also to define the role of the local public health department in this new era. So I began with the literature review, looking at published work related to expanded health coverage, immunization rates, healthcare access, in particular in rural communities, and also changing roles of local health departments in response to the Affordable Care Act. And I identified common themes to address in my key informant interviews and survey. So phase one began in the last fall, and I conducted key informant interviews in 4 counties. And this included interviews with public health leaders and community providers from health departments, federally qualified healthcare centers, and rural health centers. And so the structure was around 60 to 90-minute interviews using semi-structured questions, and they were conducted both by phone, in person, as well as via WebEx. So the last few months have been for me to look at the interview notes and do a qualitative analysis to find common and unique themes. So the results from these key informant interviews, there were definitely some unique themes and some common key themes. So under the the topic, if you will, of Affordable Care Act and Medi-Cal expansion and the 317 vaccines, the key informants, the themes are that the counties as well as the FQHCs as well as the rural health centers are seeing an increased number of children eligible for services. What the local health departments noted was that there's been a decrease in publicly insured children seeking immunizations as compared to prior ACA. Immunization rates. The key common themes are that underinsured children face barriers to timely immunizations. So underinsured children typically mean that the family has private insurance, but that there are high deductibles or high copays. And so we noted that it was difficult in the 4 counties for the children to get timely appointments, especially for kindergarten entrance. And that personal belief exemptions really can affect immunization rates in pockets in a given county. Access to immunization. So the key themes here that I noted was lack of immediate, again, appointments at community and private providers. Community partnerships are crucial to improve rates. This really means that we noted what's a common theme around 4 counties and across the agencies was that the acknowledgement that in order to maintain high coverage rates as compared to the state, that new models had to be formulated, that local health departments had to work with FQHCs, rural health centers, as well as private providers to make sure that the children are immunized in a timely manner, and that barriers, personal belief exemptions, or information or correct information needed to be given, and that it would take a partnership. So what I saw in the 4 counties too was the formations of work groups, immunization work groups, and coalitions just to address access to immunization in order to improve the rates. And what was another common issue, a common theme, was that uninsured children, it wasn't an issue for them to receive immunization if they can get in because of the availability of VFCs and 317 vaccines. Funding for immunization was another topic, and the key themes here are that local health departments, these 4, experience a decrease in state funding for immunization activities. In the interviews with private providers, I noted that what was a common theme was that there's insufficient reimbursement. And incidentally, this was validated or was shared commonly at the state level in a immunization work group that I got invited to participate in, that this was said over and over and over again, that private providers, especially in small rural communities, are having a tough time because of the insufficient reimbursement and the high liability or high risk to store vaccines in their practice. And that the other key theme was that 2 out of the 4 counties really was looking at pursuing private insurance contracts in order to be able to provide immunizations to their membership. And one of the counties was successful in obtaining 13 contracts. Another topic is cost of immunization as barrier. And so the key themes here are the high costs for underinsured children. Again, this is really referencing the high copays or deductibles that the families would have to pay. And in several of the interviews, I noted that the amount that was shared was anywhere between $1,200 or $1,500 to get their child ready for kindergarten. So that what's interesting is that a lot of times parents will choose to claim the personal belief exemption in order to get a pass-through for their children. And so some of that gets reflected in the increasing personal belief exemption rates as well as the incomplete immunization rates. And again, 317s and VFCs were readily available for non-insured or publicly insured children. So that is not a barrier. The role for local health departments. So these set of questions were asked of local health department staff as well as their external partners. And so the key themes that emerged was that local health departments are having a decreased role in direct service providing immunizations for publicly insured children, for children who have Medi-Cal. But that there's an increased role in outreach and education, especially in order to maintain or improve immunization rate. But what was a resounding worry was that how would public health departments maintain their capacity to serve safety net populations with the decrease in direct services to Medi-Cal patients. So this means really having to seek new funding, seeking new partnerships, seeking new strategies in order to maintain that capacity. I wanted to share with you a few slides on the immunization rates in California. And before I do that, in case you have not heard, yesterday our governor signed into law a pretty historic vaccination bill. So California now joins only two other states, Mississippi and West Virginia, that permit only medical exemptions as legitimate reasons to sidestep vaccination. So SB 277 will require California school children to be fully vaccinated in order to attend public or private school, regardless of their parents' personal or religious beliefs. And this will take effect on July 1, 2016. So within that context, here, this graph is a depiction of the immunization rates for kindergarten entrants in California as a state. So this is the average from 2008 to 2014. And 2010 is when, September 2010 was when the Affordable Care Act made immunization available at no cost to children newly enrolled. And so you see that it's pretty, as a state, it's pretty steady in the 90, high 80s range. But when you look at the red line, the trend is pretty steadily increasing for the personal belief exemption. And the yellow line is the personal medical exemption rate. And that, throughout the next 4 slides, is pretty consistent at less than 0.5%, so pretty negligible. So while if we look at California, the rates are pretty high in the 90s, high 80s. We find a different story when we drill down to the county level. So this is Nevada County. And so the rates range significantly lower at anywhere at the lowest point, 66%, to the highest in 2008 at 77%. Um, and what's interesting to me is the increasing rate of personal belief exemptions. And again, what this does not necessarily mean that the parent has an objection to the vaccines per se. What I found in interviewing the public health department staff was that, again, because of cost, the expedient way may be for the parents to say, I have a personal belief exemption, and thereby getting their child into kindergarten and bypassing the rule, the mandate. And again, here, the yellow line, the PME personal medical exemption rates are pretty insignificant, ranging very, very low. In Shasta County, another rural county up north, we also see a fluctuation in the up-to-date kindergarten entrance immunization rate. And again, this still falls below the state average. And you see the red line mirroring almost, not to the same extent as the previous Nevada County, but steadily increasing in the personal belief exemption rate, with PME pretty much very, very low. And in the 4 or 5 counties that I looked at, I didn't see any significant PME rates. So Humboldt County is Susan's county, and we also see a steady rate for immunization, still falling below the state average. But what is reflected here, like other counties, is when you have in 2012, actually in 2013, when there's a dip in the immunization rate, it's also mirrored in an increase in the rate of personal belief exemptions for that period in time. So these are the 4 counties that I picked because they had the higher personal belief exemption rates. Kings County is an anomaly because while it is also a rural county, a small rural county, they have amazing immunization coverage rates for kindergarten entrance, higher than the state average, and very, very extremely low both medical exemption rates as well as personal belief exemption rates. And what's interesting to note is that Kings County, unlike the other Northern California rural communities, is in the San Joaquin Valley, so totally different communities, very much more diverse in terms of socioeconomic characteristics, and so and that is also mirrored by Madera County as well. So what we have concluded in our key informant interviews and discussions with our reference counties is that local health departments have a few concerns. One is that given the changing landscape and that kids in the community are getting immunized, how do local health departments maintain the capacity for mass vaccination efforts? And how do they maintain or support the immunization coverage rates, and in some cases need to improve without the ability to provide immunization services to really anyone who seeks it, without referring back to a medical home, without referring back to an FQHC or a rural health center? The other concern is how do we capture the cost um, in between how local health departments are, what is it costing them to provide immunization versus community providers, especially when the two accounting systems, the two costing systems are drastically different. Um, so in terms of immunization rates, the key informants agreed that yes, the rates can be and should be improved to reflect or exceed the state average. But how? And a lot of unknowns, how to do it, and who are the children that can benefit from targeted focused attention in order to improve immunization rates. So from that, three models or three arrangements were discussed, or the themes. One is that the local health departments stepping away from direct services to Medi-Cal insured children. The other model is going after and competing with private community providers for the privately insured children. And the third is, and it's not exclusive from the first or the second model, is spending more efforts, spending more resources on referrals to other providers and convening coalitions and work groups in order to improve rates. So having the big picture about the role of public health as the convener, as the advocate for improvements in immunization rates. And so what that leads me to the second phase in the study, which, so I found that looking at the state level immunization rates really was a different story when we looked at county rates. And so I'm in the middle of analyzing the state immunization database at the zip code level, because when you have a county, even with high immunization rates, there are bound to be pockets of communities where the immunization rates are drastically different. Also finalizing a survey based on the key informant information to all 58 counties, so expanding the study to large counties as well. And then analyzing the survey responses for themes and costs from the 58 jurisdictions. And hoping to construct a predictive model for immunization rates. So who are the children that's not immunized, and what are the predictive factors in order for local health departments to really focus and target their efforts. So the final products this fall is taking from the DAC study and taking information from the survey to have a cost estimation for childhood immunization services, at least among local health departments. I'm planning to this winter and next spring to present brief and to distribute briefs on the survey findings as well as predictive model to assist local health departments and their community partners. And then my dissertation defense is for January 2016.
Thank you very much, Vaughn. And we'd just like to remind everyone that you can type your questions in the chat box lower right. But before we get to our question and answer period, we'd like to first introduce our two commentators who will be providing commentary in Vaughn's presentation. Our first commentator is Dr. Paul Brown, who is chair of the Public Health and director of the Health Sciences Research Institute and School of Social Sciences at the University of California, Merced. Paul received his PhD in economics from the University of Wisconsin, and his previous academic positions include the University of Massachusetts, Boston, University of Auckland, New Zealand, Auckland University of Technology, and University of California, North Carolina. In addition, Paul has worked for several governmental agencies, including the Pennsylvania Resource Council, the Ministry of Health in New Zealand, and Environment Waikato. Dr. Brown's research interests include health disparity issues, including detection of socioeconomic determinants of health, such as income inequality and stroke incidence, identifying the burden of disease and access to services for elderly and people with chronic conditions, and the effectiveness, cost-effectiveness, and sustainability of health services aimed at reducing health disparities for vulnerable populations. Paul is also the research mentor for Vaughn's PPS PhD Award, and he also co-led the California PBRN DAC study. Our second commentator is Susan Buckley, who is the Public Health Director in Humboldt County, California. Susan received her MPH from the School of Public Health and Community Medicine at the University of Washington. Susan has been a public health practitioner for over 22 years. In addition, she chairs the Executive Committee for First 5 Humboldt, the County Commission for Children and Families. First 5 Humboldt promotes comprehensive, integrated early childhood development services in order to foster secure and healthy children able to develop their full potential. Though Susan presently oversees all public health programs, her career began in maternal, child, and adolescent health programs, and that population continues to be her driving passion in community health. So with that, I'd like to turn it over to our first commentator, Paul. Feel free to give your commentary.
All right, thank you very much. And thanks to everyone for joining on a summer afternoon. And Vaughn, thank you. That was a great presentation. This is I'll just say at the start is that Vaughn is she's the ideal PhD student because basically she's just doing all this by herself and does it very well. I think that what my reaction to this is that is kind of to show my naivety coming into this. Because I had assumed that what would happen is that we'd get in there and find out that public health departments were kind of drawing back in terms of the services that they're offering and becoming less of a service provider and more of a monitoring the services and a pass-through. And I think the situation looks like it's a lot more complicated than that. And that, not surprisingly, is that they're kind of reacting to what the local conditions are. And in this case, it seems the local conditions are partly is what the other providers are doing. That is that what the constraints that they face. And then the other thing is what's happening in the community, like in this case with the high level of people who are opting out of getting vaccinations. So I think that the model becomes a lot more complicated, and it also becomes a lot more complicated to try and figure out. So how do you blend that with also the fact that public health departments seem to be kind of in this transition period where they're still trying to retain some of the things that they used to do and trying to retain some of their capacity for doing the kind of emergency type stuff, but moving into this new era. And I think that the research that Vaughn has done here is kind of, to me, suggests that it's giving hints in terms of what some of these models might look like that we see emerging in the future. And I'm really interested to kind of see what happens when you start to look at more of the local conditions and try to identify what type of process counties are going to go for.
Thank you, Paul. Susan? Susan, are you online? I think, Anne, could you follow up on Susan if she might be having some technical difficulties?
Okay, will do.
All right, so while we wait for Susan to get online, or we can try to resolve the technical difficulties, we can open up the floor to questions. We can direct it to Vaughn or to Paul or to our commentators. And is that you, Susan?
Hi, Susan Buckley here. Sorry,
okay.
I managed
I'll hear your commentary first then. Go ahead, Susan.
Okay, thank you. First of all, I want to say I really share Vaughn's excitement at the California's governor signing the bill that will remove personal belief exemptions. It's a very big step for California. It's going to be a very complicated path forward, but it was, a real important step. And I think I appreciate Paul's comments about, his notion that possibly public health departments would have a lesser role in assuring a full immunization status for children. In fact, I think our role is going to become more complex and more interesting as we move forward. Thinking in terms of Humboldt County, which is in the far northern part of California, the Northwest, when you look at state counties in California, every county is really different. The immunization rates Vaughn shared illustrate that. The presentation started noting that 40% of California children are on Medi-Cal now, thanks to the Affordable Care Act and the Medi-Cal expansion. In Humboldt County, that's actually 60%. Simultaneous with the Affordable Care Act expansion, Humboldt County entered a Medi-Cal managed care environment. The managed care provider requires that children receive their immunizations from their PCPs. This makes complete sense. This offers us the opportunity not to miss opportunities for vaccinations, but also our service quantities, our patients that we were seeing in the Humboldt County clinic, it just plummeted. We have one less nursing staff now in that clinic, and our clinic assistants numbers have dropped as well. So while in principle we certainly support that parents seek their immunizations at their PCPs, this had a big impact on our clinic business. We established an immunization coalition in early 2015, and we're in the process of understanding barriers, including PBEs, and what drives parents to seeking a PBE, to understanding those better. A very important voice in this coalition are parents, are pro-immunization parents. I think many of us public health practitioners are beginning to understand better an increasing lack of trust in government and government agencies on the part of our communities, and I think engaging alongside of us that parent voice is really important going forward. Rural local health jurisdiction revenue streams are decreasing because at the clinic service level we're serving fewer numbers. But that I want to echo also that the importance of us maintaining safety net capacity. When we do that, when we maintain capacity and have decreasing revenue streams from folks, from families using our clinic services, that digs deeper into already shrinking core public health funding and just simply will be an ongoing challenge. In looking at Vaughn's descriptions of the possible types of what public health clinic and immunization services will look like, I think as we go over, the next year as the impact of the PBE removal, as we understand that better, as we see hopefully increasing immunization rates in counties like Humboldt and Nevada so that we more like mimic Kings County, I think those three proposed models will actually evolve and kind of hybridize a little bit going forward. Yeah, I agree that public health roles, in contrast, our direct service may diminish, but our role in assuring optimum immunization rates for children is not going to go away and will probably increase and become more interesting. Thank you.
Thank you, Susan. And so now we have around 10 to 15 minutes to receive your questions and direct your questions to our speaker and our commentators. And I think we have already a couple in the chat box. Kaja asks, and Vaughn, you can answer this, or either you, Susan, or Paul. With the new bill in California on mandated vaccination among school children disallowing personal belief exemptions, how do you think it'll impact the current gaps in immunization among children in general and among the uninsured documented immigrant children in California? So any thoughts on that?
I have some thoughts.
Go ahead.
I think that from just monitoring the social media, I don't think that parents who hold personal belief exemptions for religious or personal reasons will give that up just because SB 277 has been signed into law. So the option for those parents are to homeschool their children. So in terms of disease, I think that the gap will continue. In terms of pushing back at the mandate, I think that will continue. So I think that the strategies that we hopefully will develop for the local public health departments, the model, how can you look at your zip codes? What are the factors that you should be cognizant of in order to improve immunization rates will still hold true, even though now we've disallowed personal belief exemptions. The other question has to do with the uninsured, undocumented children. So also recently, Governor Brown in the state budget has expanded medical care coverage to all children, whether regardless of their immigration status. Furthermore, the state risk pool for indigent care has expanded that coverage to their adults, to their families. So undocumented children and adults will have complete Medi-Cal coverage in essence. And so I think that that in combination with the key informant interviews, it doesn't appear that uninsured children are an issue. It's the underinsured children who might be the ones that are not getting immunized. Susan or Paul, do you have anything to add? Or?
Well, I was wondering, Vaughn, do you have an idea about if you look at those personal the exemptions, what percentage of those are due to more economic considerations rather than due to choice?
No, and so I'm hoping to do that in my second phase because I'm looking at zip code for each county. I'm delving deeper into the zip code level and interfacing that with census data. So I should be able to have a good idea in a few months.
I would agree. This is Susan. I would agree with Vaughn that that's the population that I worry about the least, frankly, going forward. Because even right now, before the Medi-Cal coverage for the undocumented starts in California, we are able, as long as our clinic infrastructure is intact, we can immunize those children here at Public Health using VFC.
So Kaja has another question, and he's wondering if you guys have any idea what the incidence of infectious diseases that is attributable to the immunization coverage below herd immunity in different counties of California?
I don't have the specifics, but I know that with the last measles outbreak, we call it the Disneyland measles outbreak because that's where the index cases were, that the pockets of measles occurred in zip codes that had higher than average personal belief exemptions. Susan, Paul?
The only thing I might say, we have a continuing high level of pertussis cases in California. Pertussis, however, is a very complex situation from disease levels in community, relating to a less effective vaccine, waning of the effectiveness of the vaccine, et cetera. But we continue to see, I keep waiting to hear from my lab and communicable disease staff that we're seeing fewer cases of pertussis, but that is not yet the case.
So we do apologize for some of the technical difficulties when it comes to the lag, and when you type in your questions, it doesn't appear immediately in the chat box. But just a question, Vaughn, about your presentation. You did mention about funding for immunization, that there was insufficient reimbursements for the private providers. So I guess my first question is, what percentage of the immunizations are provided by the PCPs, and what percentage are provided by, the LHDs, for example, in their direct services for these child immunizations? And the reason why I ask that is because there's some anecdotal evidence that's coming out here in Kentucky that, private providers under, for children who are enrolled in Medicaid as part of their SDT or well-child visits, part of that bundle includes administering vaccines during the well-child visit. But what some of the LHD personnel here are finding out is that the physicians are not performing those immunizations, instead are shuttling them or sending them to the LHDs for them to immunize the children. And ironically, of course, the physicians are reimbursed for that, but the LHDs receive no reimbursement for administering those vaccines. So I was just wondering if, that problem of insufficient reimbursement for private providers are causing are creating some of that phenomenon of them relying instead on the LHDs to perform the vaccination.
So when I interviewed in the 4 counties that I interviewed, CB, I only found that occurrence, the dumping, if you will, or the referral, go get your shots from the local public health departments in 1 county. So I'm hoping to capture that information in the 58 county survey. But so only 1 county had that experience that you just shared. Another county, it's more intentional. They have an arrangement with private providers and private insurance companies to provide shots for their membership, and it was intentional because the public health department could operate extended hours, had more of could bear the risks, the financial risks, whereas the private providers were unwilling. So that I got that only from 1 county.
Okay. I guess, Anne, I'm not sure because I'm not seeing Charlotte's question appear on the chat box yet, but I guess for another question for Vaughn, you did mention the next phase of your study, which is to take some of the results from the DAC study and apply that to your analysis. I was just wondering if you could just expand on that a little bit of how you're going to be using those information from the DAC study and incorporating that into your study for further analysis.
Sure. So from the DAC study, we, in a 30-second elevator speech, so the DAC study sought to capture the costs for childhood immunization in the San Joaquin Valley. So we use 2 methodologies. We use the resource-based costing, and we use reported costing. So we have an idea of the range in both methodologies, how much childhood immunization in order for kindergarten readiness, how much that range should be. With the current study, we're approaching it from a resource-based, a reported base, because we couldn't go in and look at the resources. So I'm hoping to apply some of the range of costs that we got from the DACs and apply that to the information that we're getting from the surveys to the 58 counties. So in the survey, that's to be distributed. It's really high-level cost information that's basically in their budgets and not necessarily delving into the resources.
Anne has a question, again, to the group. Will you be able to look at the impact of the economic recession on the PVE rates?
Yes. So the database that I'm hoping to integrate, I'm hoping to pull in census information as well as NACCHO forces of change and profiles of local public health departments, and integrate that with the immunization database at the zip code level. So yes.
And then Charlotte has a comment. My understanding is that the children whose parents have ACA insurance would have all childhood immunization reimbursed at 100%. Please speak to those considered underinsured children, since there would be far fewer of those situations. For example, LHDs in Wisconsin can administer childhood immunization to the underinsured children. So any thoughts on that?
My understanding is that in September 2010, for the children who are newly covered, their childhood immunization are covered at no cost. But you have residual children who parents or whose families belong to insurance companies or insurance coverage who were grandfathered in. So there may be a high deductible or a high copay. So those children would face a economic barrier in terms of getting all the shots needed, say for kindergarten entry. And it seems more than so theoretically those grandfathered programs or grandfather plans should be phased out by 2014, and our study covers only till 2014. So we might not see the residual effects unless we look at 2015, 2016 data.
This is Susan. This is one of the complexities of the Act. My legislative staff, I was under the impression that the grandfathered plans would have to, that their benefit levels would need to come into conformance with the provisions established by the Affordable Care Act. I'm advised that that is not the case, that the grandfathered plans, will, at least as the Act is presently written, and possibly, amendments will ensue, they will not be required at any time going forward to raise benefits like full coverage of childhood immunization. So our families who are currently, as Vaughn noted, real surprised with a $1,500 bill to get their child fully immunized for kindergarten will continue to face those kinds of co-pays absent federal action.
Right. And the other thing about underinsured children are not eligible for VFCs or 317s as I understand it. So VFCs and 317 vaccines are only available if the health plan does not cover vaccines or selected vaccines. So if you are underinsured because you have a high deductible or a high copay, then I don't believe that you are eligible for VFCs and 317s. And this change happened in 2012.
I think we have time for two more questions, and I see Dr. Craig Humbaugh is typing. His question still hasn't appeared in the chat box, but I think one more question is, when you came to your conclusion slide, Vaughn, what did you mean by the 3 new arrangements for LHDs in rural areas, particularly the type 1 where you're talking about does not provide immunization to children covered by Medi-Cal? Could you clarify that, please?
Sure. So in the 4 counties where I conducted the interviews, local health departments, these 4 counties belong to Medi-Cal managed care, and so the Medi-Cal managed care contract stipulates that the immunization had to be provided by either the FQHC, the rural health centers, or the private providers in their network, and not by, that local health departments would not get reimbursed for that, for the immunization. So that became a non-group or non-eligible group for the local health departments to deliver services to.
Okay. And our last question comes from Craig, who has asked, has anyone explored using pharmacists more effectively to increase immunization coverage levels in local areas?
Yes, so the Health Officers Association of California, so the state of California's immunization branch convened a work group consisting of health officers and pharmaceuticals and pharmacists to address this question, especially in rural counties. This is one of the creative solutions to improve immunization rates in rural counties. And actually, one of the interviewees that participated in this study is a very active member and a big proponent of using pharmacies and pharmacists to deliver or to improve immunization rates.
Thank you, Vaughn, and thank you once again for your presentation. Indeed, we look forward to seeing how the results are going to sort of inform the debate around this issue, especially with the new law that's been passed in California. And again, we'd also like to thank Vaughn and our commentators, Paul and Susan too as well. And we'd like to thank everyone also for joining us here for today's webinar. We'd just like to remind everyone that we do have upcoming webinars for July and August, so we hope to also have you join us for those webinars, and invites and reminder invites will be sent out as well. And just a reminder that also the archives of all our previous webinars are also available at our website at the National Coordinating Center. So with that, we would like to thank you again for your participation today, and have a happy 4th of July weekend, everyone. Thank you so much.
Thank you.